This is Dr. TSR. Today I am here to explain about acute kidney injury from our favorite book and Donald. So, acute kidney injury, it is the most important cause for maternal mortality and morbidity, where the kidney fails to excrete the nitrogenous waste products and maintain the fluid and electrolyte homeostasis. So, by the association, acute kidney injury network defines acute kidney injury as acute rise in serum creatinine within 48 hours. And they have given the classification. The classification is increase in serum creatinine more than 0.3 mg per dl, or increase in the serum creatinine 2 times the baseline, or decrease in the GFR by 50%, increase in the serum creatinine by 3 times the baseline, or decrease in the GFR by 75%, or initiation of dialysis. When it comes with respect to urine output, less than 0.5 ml per kg per hour for 6 hours, less than 0.5 ml per kg per hour for 12 hours, less than 0.3 ml per kg per hour for 24 hours, or anuria for 12 hours. Various etiology: septic abortion, hyperemesis gravidarum, preeclampsia, placental abruption, AFLP, acute hemolytic uremic syndrome, PPH, chorioamnionitis, lupus nephritis, glomerulonephritis, interstitial nephritis, obstructive nephropathy. So, each pathophysiology, when it comes with pre-renal, mainly because of the fluid loss. Fluid loss can occur due to vomiting, hyperemesis gravidarum, or because of hemorrhage. Hemorrhage means placenta previa, placenta abruption, placenta uterine rupture. All this hemorrhage will reduce the blood volume. That causes reduced renal perfusion. Will cause ischemia. Ischemia will cause acute tubular necrosis if you are not corrected. And basically it will cause bilateral renal cortical necrosis. So it mainly involves the cortex sparing the medulla. So the patient will present with flank pain, prolonged anuria, oliguria, and gross hematuria. Okay, so this is about pre-renal failure. Coming to the HELP syndrome, there is already endothelial activation. Dysfunction is there. Because of the endothelial dysfunction, they will get glomerular ischemia. Adding to the vasoconstriction, all of this reduces the renal blood flow. So you have to terminate the pregnancy. Sepsis, most common cause for AKI. The causes are septic abortion, then purpural sepsis, chorioamnionitis, and pyelonephritis. Eradicate the cause, treat with antibiotics, and give parenteral fluid therapy. AFLP, it is a rapid progressive liver disorder. So the patient will present with abdominal pain, nausea, vomiting. So the vomiting, they will exacerbate and get the renal failure. So adequate laboratory investigation like bilirubin, hyperbilirubinemia, liver enzymes more, hyperuricemia, hypoglycemia, all this indicates AFLP, terminate the pregnancy. When it comes with hemolytic uremic syndrome, you will get microangiopathic hemolytic anemia, then you will get reduced platelet count and multiple organ failure. Unlike typical HUS where there is diarrheal disease, here atypical, it is mainly because of pregnancy where there is stimulation of alternate complement pathways. So the prognosis is mainly depending on the eculizumab. So the management is you have to restore the volume whichever is depleted, and you have to treat the cause and treat the electrolyte imbalance. So all do basic investigation like CBC, HB, hematocrit, platelet count, and then RFT and coagulation preference serum electrolytes. So put Foley catheter, monitor the urine output, send urine analysis, look for microscopy. If GFR is less than 30 ml per minute, all your doses has to be changed. NSAIDs should not be given. And hyperkalemia and metabolic acidosis are the dreaded combination of acute kidney injury. So hyperkalemia you will treat with calcium, glucose, and insulin infusion. And acidosis you will treat with sodium bicarbonate. And you will proceed with renal replacement therapy, RRT, or dialysis only if the chronic kidney disease is associated with AKI, or there is volume overload and hyperkalemia which is not treated with medical or refractory to the medical treatment, and metabolic acidosis, serum urea more than 100 mg per dl. So in meanwhile you monitor the fetal FH, and once the mother condition is stabilized, proceed with delivery of the baby. This is all about AKI from I and Donald. Signing off. This is again me, Dr. TSR. Thank you so much.